Okay, so now we're going to get into the cardiac emergencies. So when we talk about AFib, A-flutter, we used to have the conversation of, well, would we cardiovert them, new onset versus they've been in it a while? We're taking that away and we're saying we're not cardioverting AFib or A-flutter anymore. So our decision is the patient stable or unstable? And what we're asking is what their blood pressure is again. So if the patient has adequate blood pressure, what drug do we give for AFib, A-flutter?
Cortisone.
Right, still cortisone. So we're changing the dose a little bit, the way we're giving it, but still think we're giving it slowly. So 10 milligrams over 2 minutes. When would I stop giving the cortisone?
If you see a change?
See a change and specifically look at the heart rate. So we wrote if the heart rate comes below 120, that would be an endpoint when to stop the cortisone. If it doesn't, then you would continue and give 15 milligrams over the 2 minutes. That should work. Now, while you're giving the cortisone, if the patient becomes hypotensive, you'd reasonably believe it was the cortisone that caused that. We would then give the 1 gram of calcium chloride and some fluid. Now, when we give the calcium, it'll actually help the blood pressure without taking away the positive effects of reducing the heart rate that we were looking for. So it actually works very well. Yes, sir.
With the saline, you got 1 liter of saline. Are we doing 500 reassess and then
Yes.
or just continue?
Yes. So we'll actually make that read the same way. Yep. You always want to reassess periodically. We picked 500, but if for some reason you think it would be appropriate to assess sooner, absolutely. Yep. Okay, so if they are hypotensive, we would first want to get the blood pressure up a little bit. And we already said anytime we're dealing with hypotension, we're going to try our fluids if appropriate, and then give our push dose epi. Once the pressure comes up, then it would be appropriate to start the cortisone. So we definitely do not cardiovert. That would be our options of treatment. So if we're talking about bradycardia, we put a rate of 50. But if we have an elite athlete, we put the EKG on, they have a heart rate of 45, and they have nothing wrong with them. Are we concerned? No. So that would be our stable. We're not worried about that. We're talking about the patient that you put the EKG on and see 45 and you're very shocked by that. They don't feel well, they're diaphoretic, and you reasonably believe that that rhythm is causing the symptoms. So as a general rule, we're used to using the atropine. So we're going to continue using atropine. So we give some fluid. We talk about doing a 12 lead. So it's not uncommon if you have a hypotensive bradycardic patient that patient's having an inferior MI. That's why we're doing that, and we'll talk about that a little bit later. So we try our atropine. We're giving it in 0.5 milligram increments. If you see some effect, you could continue, but if you don't have any other effect, you don't have to go to the max dose. It would be appropriate to go to your push dose epi. So you would continue giving your push dose epi until the heart rate came up, but more specifically, your blood pressure comes up to an acceptable range. If these don't work, you could go to your pacing, or if there are circumstances, you go straight to pacing, like a high degree block, meaning a second degree type 2 or third degree block. There's nothing saying you couldn't go straight to the pacing. If you want to consider sedation, as we said, our Versed dose doesn't change, it's the same. Now you notice for pacing, your heart rate now is 60. So there is some science behind that number, but if you start at 60, you get capture, and the blood pressure doesn't come up, there's nothing saying you couldn't increase the heart rate. So just keep in mind, it's not a hard, fast number. You are able to adjust it to titrate to the patient. Okay. So for bradycardia for kids, what is causing the bradycardia for kids? Respiratory, hypoxia, every time until proven otherwise. So when we talk about kids, we would try least invasive to most invasive. So we'd open the airway, we'd give a little oxygen. If that doesn't work, we consider putting an OPA and bagging the patient. Now we're ensuring there's adequate oxygenation. If that didn't work, that's when we would start our compressions. So now we're at our compressions. If we still have signs of poor perfusion, meaning delayed capillary refill, heart rate less than 60, we would consider, or we would go to our push dose epi. So this dose is slightly different than the dose we're normally used to on PALS. But we're confident it's going to work, so it's easier for people to think about, so we're going to try the push dose epi. So if you go classic PALS, it's slightly different, so just be aware of that. The unusual case that this didn't work, it is an option to pace the kids. Very unusual. Most people, we have a room of people in the class, most people have never paced a kid, never even seen someone pace. So this certainly would be the exception to the rule, but you notice the heart rate would be 80 and the same discussion applies. If you get capture, particularly if it's a younger kid, it would be appropriate to increase the rate if you thought that would help. Again, the Versed dose for the sedation across the whole protocol, even for the pediatric, it never changes. So once you learn it, it's going to be consistent across. So chest pain. So we show up to the house, the patient's complaining of chest pain. We do a 12 lead, and it talks about repeating the 12 leads. We need to get in the habit of repeating 12 leads. So we know just because you do one 12 lead and it's normal doesn't mean the person's not having an MI, particularly if they're symptomatic. So when we talk about someone being symptomatic, we're talking about chest pain, they're describing it as more of an area, they're complaining of nausea, maybe they're sweating. Those patients, we definitely need to do repeat EKGs. It is not uncommon to see the EKG changing. The hospital looks at our EKGs. When they do their new one, they look for differences. So it is definitely a value to us and the hospital when you get there. So we do my 12 lead, and later on you'll see verbiage of consider a 15 lead. So we're going to do training on 12 leads, and one of the components of that is a 15 lead. So the wording is we will do a 12 lead, consider a 15 lead. So when we're comfortable, we'll start implementing 15 leads, and that is looking for a posterior MI. So if we suspect an MI, the real teaching point is we're going to go to the appropriate facility, which would be what? A STEMI facility, right, exactly. So we're going to give our aspirin. So when we look at this treatment, if we said, what one drug do we know helps someone with chest pain? It's the aspirin. So we came with the dose of 324 milligrams. There's no specific reason of that dose. No one's decided this dose is absolutely the best dose. So don't read into the fact that we chose 324. But 4 baby aspirin, chewed up and swallowed, and now the next decision would be, which drug do we give? Well, we only progress if the person's still having pain. And if they are, our goal is to get rid of that pain. So in the past, we used to think we're giving nitro, there was some benefit to the heart. It vasodilates, and we thought there was better outcomes down the road, lowering mortality. We're now pretty sure the nitro does not benefit the outcome and does not reduce mortality. So the way we want you to think about it is, whether you're giving fentanyl or nitro, you're only giving it to get rid of pain, for pain reduction. That's it. So there may be situations, and the argument could be made that the better choice is fentanyl. So if you give fentanyl, you're giving it till you get the pain relief. If you choose nitro, same idea. So nitro may be given as a first-line drug, so you don't have to use one or the other. Is there any questions on that one? Yes?
It says if the patient was given aspirin within the last 24 hours, does it take into consideration any other blood thinners before you consider giving aspirin?
Good. So when we look, so in the past, we would consider, well, we're going to give it no matter what. If you reasonably think they did take it, you don't have to give the aspirin. Absolutely. You can believe that they took it. Yeah.
So it's not one or the other. You can do both. You're going to end up doing both, nitro and fentanyl. Or is it one or the other?
Typically, it's going to be one or the other. Do you have a specific?
No, if the patient's on Coumadin or something, you still give the aspirin.
No, but he's talking about just for the pain relief.
Nitro and the
If
fentanyl.
you gave nitro, could you give the fentanyl? Yes, but typically it's going to be one or the
One or
other.
the other usually.
But was your question, if you gave one, would that exclude the ability to give the other? Yeah, no,
Like
you could give the other one.
Ideally, the nitro is going to be the fastest one we can get on board before we can get an IV access to give the fentanyl.
Could, so that could be a good reason to try the
Like you
nitro?
get- Like you get 4 aspirin and a spray of nitro, and then you get a line, you can switch to fentanyl.
Yes.
Okay.
Now, typically, the nitro, what's the contraindication? Low blood pressure. So if someone had low blood pressure, you may absolutely decide to go with the fentanyl. As we use this, we may decide to change it a little bit or say, you know what, this definitely works better. So all these protocols are new for us. So as we go along, we'll put out guidance periodically and try to help everyone make the best decisions. Okay, so STEMI. We said STEMI alert goes to a STEMI center, but we didn't specifically talk about what constitutes a STEMI alert. So there's a couple different things to really realize. So we talked about the 12 lead and later on doing the 15 lead, but what would constitute a STEMI alert? You have to have a basic understanding of 12 lead and the idea of what is an inferior MI, what is a septal anterior lateral. So when we talk about the 12 lead and we talk about 2-3 AVF, then V1, so the 2-3 AVF would be our inferior, V1, V2 is our septal, V3, V4 is our anterior, 5, 6 is lateral along with 1 AVL. If you have no idea what I just said, you need to refresh on the 12 lead, at least to be able to understand what the related leads means. So when we talk about whether we call a STEMI alert, we're talking about related leads, and that involves that discussion. So then we realize that there's a difference between a convex and a concave ST, elevation. So when we talk about elevation, we're actually looking at the J point. So when you look at a EKG, you have a Q, R, S, and where that line starts going straight again is where our J point is. And when we talk about elevation and depression, we talk about it from the J point perspective. So if you have an ST that is convex, meaning a frowny face in the picture, that's the worst case scenario. So that is not good. So in those cases, it only takes one small box of related leads to constitute a STEMI alert. So the only exception to that rule would be if it's V2 and V3, because those two naturally could have elevation. But if you don't even remember that, one box for the convex, call the STEMI alert. And always err on the side of calling it, particularly if the patient's symptomatic. The other way could be convex. So think of it like convex probably is not as serious, so it takes 2 small boxes to call the STEMI alert. And like I said, we're going to go into a lot more detail with 12 leads, but for right now, if you understand that, it's a good starting point to be able to call STEMI alerts with accuracy. All these definitions come straight out of the cardiology textbooks. So that's why we chose these parameters. You notice some of the mimics here. We're no longer calling new onset left bundle branch as a criteria, so we're only going to be using those other criteria. And when you read it, there's a lot of information in here, so when you have a chance to sit down and read it, I'm sure there'll be other questions, and Dr. Farrell will be available to answer them. All right, so CHF, pulmonary edema, fluid. So we said nitro wasn't that important on the chest pain for the physiology. Well, it is very important for the CHF. So when you look at CHF, what is it that's going to save our patient? The CPAP and the nitro. So we have in there aspirin. Well, why do we have aspirin in there? A high proportion of cases, a significant amount, the reason they have CHF is cardiac in nature. So that's why there's aspirin in there. So does that mean I walk into a house, there's our patient's full up and they can't breathe, and I'm saying, please take 4 aspirin, chew these up? Of course not. So we added language, you give the aspirin if they can tolerate it and if you believe that it is cardiac in nature. So our priority is to get that CPAP and nitro on board. So the nitro will vasodilate and the CPAP will push the fluid out. So those are our priorities with CHF. Now you notice we took out all the different blood pressures. We used to say above 160, give a double tap, no max. We took all that out, and now we're doing 3 doses of the nitro again. So it makes it a little bit simpler for people to remember. So now we talk about cardiogenic shock. So by definition, the patient's blood pressure is low. So they may have fluid, they probably have fluid, but their pressure's low. So it talks about follow the CHF protocol. But if we go back and their pressure's low, we don't use CPAP and we don't use nitro. So how do we help our patient? Well, yeah, we talked about whenever you have low pressure, we're giving fluids if appropriate. Well, in this case, it wouldn't be appropriate because they already have fluid on the lungs. So our next option would be our push dose epi. So if you think about give the push dose epi, get the pressure up a little bit, and then use the CPAP. So don't split hairs on the blood pressure. If you feel comfortable, it would be appropriate to use the push dose epi while you're administering the epi. So that might be another case where you slightly deviate from the protocol, where technically maybe the pressure's a little low, but if you understand the mechanism and the physiology of what's going on, it'd be very appropriate to place the CPAP while you're raising the blood pressure with the push dose epi. If you don't feel comfortable, it would also be appropriate to raise the pressure first and then place the CPAP. Does that make sense?
The PEEP stays the same on the CPAP?
Yes, we're going to stay with 10. But now with the model we have now, we can adjust it. But yeah, for the CHF, we're going to stick with 10. Absolutely. Okay, so SVT, narrow QRS. And when we look at these rhythms, we're really asking ourselves, is my patient stable or unstable? If my answer is stable, I'm going to typically try a drug therapy or something less invasive like a vagal maneuver. There's a lot of discussion out there of which vagal maneuver is better. Right now, we're going to just say vagal maneuvers. We may get specific down the road of which ones we'd want you to try to use. So I do my 12 lead, 15 lead if appropriate, and now I decided my patient is stable, so I have time to try vagal maneuver. Hopefully it works. If not, I'm going to try to give my adenosine. So I'm going to go right to 12 milligrams. And what do I need to remember about adenosine? Right, the short half-life. So I want to make sure I have my flush readily available to push in, otherwise it's not going to work properly. So I try my adenosine and it doesn't work. So now I'm going to move on to giving cardizem. So we give cardizem for 2 reasons. One, it could break the SVT. But the second reason is if we were wrong and it was actually AFib or a flutter, it will work for that as well. So same discussion with the cardizem. We're going to give the 10 milligrams first over 10 minutes. If heart rate drops, we stop. If not, administer the 15 milligrams. And then if the pressure drops, we see the fluid and the calcium again. So that's the same idea as when we were talking about in the previous slide. If the patient's unstable, you could still try the adenosine because it's done quickly if they're alert, but your thinking would be, I need to use electricity or more specifically cardioversion for the patient. So you could consider sedating if you have time, and what joule setting am I cardioverting at?
360?
Yeah, that's not a typo. So we're going to start at 360. So all the cardiologists, well, most of the cardiologists agree cardioversion is very safe. The reason we might have been having issues in the past is we weren't using appropriate joule setting. So that's not a typo. We're going to start at 360 when we cardiovert. Okay?
WPW.
Thank you. So why do we have a picture of WPW there?
It's not everybody will EPA. Depending on the status of the patient, they can't tell you they have Wolff-Parkinson's White or maybe a family member or historian on it.
Good. So this gives you a fighting chance to be able to identify WPW. The vast majority of patients hopefully will tell you I have WPW. Why would we want to know that? Well, we would not want to give adenosine and we would not want to give cardizem to those patients. If you do, they have pathways, they have external pathways, and we could actually hurt or kill the patient by giving them those drugs. So we do not carry a medication to treat WPW. So if we did have that patient, what would be our options? Either just transport, or we would then cardiovert. So we would not give adenosine or cardizem to a known WPW patient. Okay? Did you want to comment on that?
Just that it's called a bundle of Kent that they have, and you can see the delta wave on the EKG strip there. If the patient has its AV node blocked with adenosine or cardizem, then the current will go straight through the bundle of Kent, and it'll be an uncontrolled, rapid rhythm, and you won't be able to get the patient out of it. You'll probably kill them. So it's very important.
The 360 is multiple, like
360 more.
multiple times.
Yeah. We're going to actually, that was one of the things, we're going to add that language of repeating it. And yeah. What we're told, most likely we're not going to have to. It's going to work. But we will add language just in case. So for the kids, make sure you remember the parameters for child 180 and infant 220. So those numbers are the numbers when you would reasonably think that that was the rhythm was the reason the symptoms were happening. Below that, maybe it was another issue, and maybe the rhythm was sinus tach. So same idea, stable vagal maneuver, drug, but if they become unstable, consider sedation and then the sinking. So our sinking, the Joule setting changed slightly. We were at 0.5 to 1. Now we're just saying 1, and then you can increase up to 2. Okay, so wide complex tachycardia. So wide complex tachycardia, we're talking about a QRS of greater than 0.12. That's only 3 boxes. That's not very wide. For kids, it's even less. It's 0.09. So in these cases, that's what we would start considering wide complex tachycardia. So if you notice, the rate is greater than 120. So before we were saying, well, what if you thought it was hyperkalemia? Well, we're describing a rate of 100 to 120. You have a wide QRS greater than 0.2. So that's greater than 5 boxes. It's going to look weird to you. The QT's wide. So we said you were all excited to wait for the slide of what you wouldn't give. So what drug would I not give if I suspect there was hyperkalemia? The amiodarone. You'll kill the patient if you give it to them. So that's one thing to look out for. And the key is how wide the QRS is and the rate. So the normal wide complex tachycardia will be above 120. And again, we're deciding, is the patient stable or unstable? I decide stable, I'm going to try my infusion of amiodarone, 150 milligrams, into a 50 bag, 1 drop a second using my 10 drop set, and I infuse it over the 10 minutes. Okay? If they become unstable, or you decide you want to try the sinking, the Versed dose does not change, and what is my Joule setting? Still the 360, right? So this talks about if you cardioverted them and you converted it, would you give the amiodarone drip? So now the verbiage is if it took 1 cardioversion, no. If it took 2 or more, you would give the drip. So the idea is you're trying not to give drugs needlessly, particularly ones with long half-lives like amiodarone. But if it takes more than 1 cardioversion, then we would give it. They need the antiarrhythmic. All right, any other questions on this protocol? There's a lot on that page, so obviously it's going to take time to digest it all. Okay, so polymorphic VTAC. So before we were talking about wide complex, we're talking about a monomorphic, or the waveform's all the same. Now we're describing a polymorphic where it changes. So the one we're most familiar with is the Torsades point. So a lot of the protocols will say try to sync, but be aware that sometimes you're unable to get capture and then you would defibrillate. We opted to go straight to defibrillation. So that is not a typo when you read defibrillation. But what would be the anticipated treatment for Torsades? Yes, still MAG. So always 2 grams, doesn't change. So we give our 2 grams of MAG over our 10 minutes. If they become unstable, that's when we can consider defibrillating them. All right, so that defibrillation is not a typo. Okay, so ventricular assisted device. We're used to it reading left ventricular device. They can be on the right side as well. That's why we took that language out. The key to this protocol is where would you take the patient? We have several patients in our city. If you ran that call, where would you go? My advice is that person is assigned a case manager. Call the number and follow their advice. If it is something to do with the LVAD or the VAD device, they need to go to a VAD center, Cleveland Clinic or Memorial. Right now, those are the only centers that install them. So, as Dr. Farrell has mentioned several times, Holy Cross, they don't install them. They don't have all the equipment. So if it is a problem with the VAD and you bring them to a facility that can't handle it, you risk that patient dying because we went to the wrong facility. It's a specific batteries, a specific equipment that they have to be able to treat these patients. So as of today, the only centers that we're comfortable to transport would be Cleveland Clinic or Memorial.
There's no helicopter landing.
Right. The other reason or the other consideration would be you would want to go somewhere that had a helipad to be able to transfer them as quickly as possible if needed. So that might arise if you're deciding, well, the problem's not with the device, it's a non-VAD related problem. Couldn't I go to anywhere? And the answer is yes. But if they're going to get admitted, they're going to have to get transferred because that facility isn't familiar, doesn't have the equipment with the VAD. But if you call the case manager, they'll walk us through the process. All right, any questions on the VAD? We're going to see this more and more. When they initially were putting them in, it was people waiting for heart transplants. Now they're using them for different reasons. So we're going to start seeing these more and more. And as things evolve, we'll change where we can go most likely, and we'll keep everyone updated. Okay, let's take a break, and then we're going to get into the cardiac section.